Hi, everybody. Good afternoon. The first thing I'm going to say is that in very stark contrast to Stephen and to a lesser extent John, I am not going to tell you what I did in the 90s. It would be too embarrassing. But I do want to talk about a few of the things that I do when I work with clients. Maybe though, before I do that, I'll just share one brief experience. When Aner and Yael invited me to the conference here to speak, and they said it had cognitive behavior therapists and psychodynamic therapists and integrative therapists. My first thought when I saw that was, I wonder which group I belong to. I wasn't absolutely sure. I mean, I self-identify as a CBT therapist, so obviously I can belong to that group. Am I integrative enough to be an integrative therapist? I don't know. I kind of liked not knowing, by the way, which group I belonged to, and then later on they sent the panels, and I could figure it out. But I just wanted to say that not knowing, was kind of nice, and maybe has something to do with, why we're all here. So I'm a professor at the University of Haifa. I'm a cognitive behavior therapist. I did receive psychodynamic training. A few of the people sitting here have trained me. Eva was my PhD supervisor and a huge mentor for me. Golan was one of my professors in grad school. I've learned so much from other people here around this table. Actually, Aner taught me as well. You did one course. It was ages ago. Yeah, it was short-term psychodynamic psychotherapy. So I did get psychodynamic training, but I do consider myself a cognitive behavior therapist. My research is, and we started talking about this at lunch, is about social anxiety disorder, which is one of the psychopathologies that I focus on the most, as well as sudden gains that happen during treatment, which are fascinating to me. It's something else that we do research on, sudden gains, something that I was taught was not supposed to happen. In psychotherapy, you're supposed to get better, little by little, and that's real change. Turns out it doesn't really work that way. Many people experience sudden improvements that last a long time, and I always thought to myself that by studying these rapid improvements, we could maybe learn a thing or two about treatment. So I've been doing that as well. But I want to be talking, I'm going to talk about a few things about the way I work with clients and about some of the principles that I use all the time. The first of these is that I'm a huge believer in learning through experience. And I prefer learning through experience over talking about things, learning about things, to a large extent. I think experience is the best teacher, and everybody here talked about it in some way or another, right? John mentioned it, how experience is so important to psychotherapists. You start out, you're young, you have no experience. That's so different than 20 years on. Not to mention that we all know that even if I read, the collection of Freud's work, it doesn't make me a good therapist. Something else is going to make me a good therapist, and it has to do with, at least in part, experience. Golan talked about it before when he talked about his, professional experience and how that shaped him. He moved to another country, different theoretical orientation, and how that helped shape him as a professional. Experience is the best teacher. And so what I try to do is I try to provide clients with experiences that are going to be helpful for them, that they can learn something from, that are going to help them grow. And I think in her first talk in the morning, Yael mentioned something about exposure and how that's like one of the central interventions in CBT, and it's something that I use a lot. And actually, that's the way I see exposure, as providing clients with new experiences that they can learn from. That's what exposure is. It's doing something you don't normally do, experiencing something different and learning from it. The first example that comes to mind is one of my clients with OCD that really talked about this new experience thing. We were doing this exposure in my private practice. We went downstairs, and I have this doormat in front of the door where, people wipe their shoes before they walk in. So we placed our hands on it to get dirty. And then we went back up to my private practice, and we spent the entire session with dirty hands, something we would never do. An exposure exercise in the context of OCD. This is pretty normal for CBT, CBT therapists who treat OCD. We do a bunch of, things we would not normally do in any other context. But there was something that client said to me that at the end of that session that I can't forget. He was looking at his hands, and he said, this is the first time ever I think my anxiety dropped without washing my hands. It was the first time. And he was amazed. He never thought that could happen. The only way he knew to reduce his anxiety about being dirty was washing his hands. It was the first time we sat for the entire session until his anxiety dropped, and he had this novel experience. And I think, that's the first example that came to mind about how this technique could really help to bring about new experiences and then, process them and learn something new. So I think that's a really important aspect of my work. We were talking at lunch about how I don't like doing, kind of old school cognitive work about, cognitive restructuring and identifying, biases in our thoughts. There has been a big shift in cognitive behavior therapy. David Clark is talking about how he doesn't do cognitive restructuring anymore. That's a huge shift. So I'm a big believer in what he calls behavioral experiments and what I would call, creating these new experiences we can learn from. Another important thing I use when I work with clients is I find myself externalizing or personifying aspects of people's self. Like some of their emotions, we treat them like characters in a play. A lot of the time I would tell my patients things like, you walk into the situation and then anxiety comes along and it's telling you this, this, and this. And it's up to you whether, what you want to do with this. Do you want to believe your anxiety? Do you not want to believe your anxiety? Do you want to play along with it? Do you not want to play along with it? Making anxiety a character, a person, is, and not just anxiety, of course, we can do this to anything, any internal, part of the self. I find that really, really helpful in my clinical work. We were talking about these things a little bit before when we talked about how some clients really hang on to their symptoms or don't want to let go or identify with their psychopathology to a huge extent. If that's the case, if I try to treat this psychopathology, I risk working against the patient in some way because the psychopathology is really a part of the self. And we don't work against clients. We work, to help clients. And there's something about using this externalizing narrative that really helps me in my practice. And I've seen a lot of other people do this. I didn't make this up. I've seen some of the best therapists I've ever seen in my life do this all the time. Is really separate clients from some of the more problematic or pathological aspects of their own behavior or feelings or thoughts. And that helps you create a better alliance with the client to work together on these different parts. If I think I have this priming because I just talked about this client with OCD, right? But I can see myself telling that client things like, you're a really great person and a healthy person and you care about being clean, and that's fantastic, but the OCD is driving you mad. It won't let go. It's unrelenting. It keeps telling you to do it again and again. And we can start separating the client and the obsessions a little bit. That also helps to do something that I think we all know is really important in therapy, and that's to cultivate kind of this stance where we can really start looking at ourselves and perceiving ourselves from a certain distance. We're not totally fused with our pathology. We can start looking at ourselves, taking a step away. And I find this thing is extremely helpful to me in my work. The last thing I want to talk about, or I want to mention here, is that one thing that I think really helped me to become a better therapist over the years is to look at some of the interventions we use all the time from multiple perspectives. Because, for instance, exposure was developed from a behavioral tradition with a behavioral rationale. But that doesn't necessarily mean that that's the way exposure works. I can think about many other ways that exposure could work and help clients. And thinking in those ways has really helped me as a therapist. I'll give you 2 examples. There's a cognitive view of exposures suggesting that exposures are actually a way to test out your beliefs about yourself, about your emotions, about the world. So if I think that Jonathan is angry with me and doesn't want to talk to me, and I keep avoiding him because, well, he's obviously angry at me, I'm never going to encounter information that disconfirms my belief. I have this story in my head, and it sticks with me. The only way I can learn something that's different than that belief is to actually go talk to Jonathan, and then I might see that he's smiling at me, that he wants to talk to me, that he's inquiring about, it's been so long, what have you been up to? And that's the only way I can get, information that disconfirms my beliefs. And you can look at exposure that way, as setting up opportunities to receive information that's inconsistent with what you believe. And that's really important, or a different way of looking at exposures. Another way that's helped me significantly is also looking at exposures as emotional interventions, as a way to feel emotions fully, to the max, without trying to run away from them, without trying to hide, without trying to fight them. In exposure, we deliberately set out to feel bad, in a way. It's mostly negative emotions. So looking at exposure as a chance to feel in the fullest sense is a different way to look at this intervention, and one that's helped me considerably. I think that different clients also resonate with these different rationales in different ways, so it's really nice to be able to use them flexibly. And maybe I'll just add that, talking about this really makes me connect with this idea that despite the fact that different interventions were developed or you know, stem from different traditions, you can see them in so many different ways. I'm sure you can look at exposures from a psychoanalytic point of view and see other things. It just enriches our understanding of this intervention. And most people who do psychoanalysis will not say they do exposure. They won't call it that. But I'm sure in many instances they would be happy for their clients to experience things, you know, novel experiences, or behave differently in the context of an important relationship and see how their partner responds. That completely can be construed as exposure. And I'm sure it's the other way around too, right? That cognitive behavioral therapists, we don't often tend to say, you know, I did this transference interpretation. We just don't call it that. But we do similar things all the time. Last thing I'm going to say is, and I'll just throw it out there so we can all discuss this. Tell me if you think similarly. I think Nancy McWilliams said this, but she said that pretty much incompetent therapists who are psychoanalytically trained and cognitive behaviorally trained are very different from each other. If you're a bad therapist, bad CBT therapists are very, very different from bad psychodynamic therapists, but good CBT therapists are much more similar to good psychodynamic therapists. And that's a really interesting idea to me. I think she has a really, really good point. And I think some of our conversations about whether, you know, these two different schools are more overlapping or less overlapping kind of depends on the quality as well. If you want, I can tell you about examples of how I heard bad CBT therapists and bad psychodynamic therapists talk about similar situations and make, you know, very big mistakes. Opposite mistakes, but similar, about the same things, and how, I don't know, I tend to think that the good therapists do have a lot of things in common. I'll stop here.
Thank you. Thank you so much, both of you. Would you need 5 minutes break before we start again? Okay.